Hello, I'm Dr. Marissa McNatt. I'm one of the breast surgeons here at Wake Forest Baptist Health, and I'm here tonight to talk about breast cancer and treatments. A little background on myself. I'm a surgeon by training. I went to medical school and then did my residency at Emory, and then I did specialty training. Did a breast surgery fellowship at Massachusetts General Hospital, and I've been at Wake Forest about 9 or so years. So my specialty is only dealing with ladies with breast cancer and some men. Also deal with people with benign breast disease, so disease that's not cancer, but they may have a problem with their breast and not really sure what it is, and I help to diagnose them and figure out what's going on. So we're here tonight talking about breast cancer, and breast cancer is a very common cancer in women. In North Carolina, it's ranked 18th in breast cancer incidence throughout the country. And Forsyth County here has a very high incidence of breast cancer. For women, as you may know, it's the most common cancer in women in the United States. So really, who is at risk? Well, mainly people with breast cancer are women, but the people at highest risk are all women as we get older. So age is the #1 risk factor. So as women get older, especially postmenopausal, so women in their 50s, 60s, 70s, 80s have a higher chance of getting breast cancer. The other people who are at high risk of getting breast cancer are women who have a strong family history. So what we call strong are women who have what's called a first-degree relative of breast cancer. So that's mother, daughter, sister. So people who are very closely related to you are at highest, and if they have a breast cancer, then you're at highest risk for developing breast cancer. And that's kind of linked a little bit to the breast cancer gene, or the BRCA1 and 2 gene. Usually those people have a family incidence of breast or ovarian cancer, and they're at high risk of developing cancer. Breast cancer is very, very common in the United States and worldwide. It's a very common cancer in women. And actually, it's easier to diagnose nowadays than it has been in the past. The best way to diagnose somebody with breast cancer is through screening, and that's through the mammogram. So we're here in Breast Cancer Awareness Month, so this is the month we encourage everybody to get your mammograms, because if you diagnose breast cancer at an early stage, it's definitely more treatable. So here at Wake Forest, we also offer something that's called 3D mammography. And 3D mammograms are a little more different than traditional digital mammograms. Traditional digital mammograms, this gives you two flat pictures. But with 3D mammography, you receive a mammogram, but the radiologist can basically scroll through the whole mammogram. So there's hundreds of pictures. So the beauty of 3D mammography is that, let's say if this is the mammogram and someone has especially dense breasts. So if this is a density on your breast, as a radiologist scrolls through it, they could see the next slide that there's some mass hiding behind the density. And if you had a regular mammogram, you would just see the area, not the little ball back here. So the 3D mammography really helps to tell people, especially women with dense breast, it helps to diagnose cancers at a smaller size and therefore earlier stage. So we offer the 3D mammography at all our sites at the Cancer Center, at our imaging in Clemens, and our outpatient imaging center on Stratford Road. So all our areas offer the 3D mammography. And anybody who thinks they have dense breasts, especially women in their 40s or other ladies, I definitely would encourage you to get the 3D mammography. So let's say if somebody had a mammogram and they saw something suspicious on the mammogram. What we do first is we biopsy the area, or try to figure out what it is. A lot of women present without having a palpable abnormality, but they'll see something on the mammogram. So we can biopsy either by using ultrasound and seeing with that, or we can do something like a stereotactic core biopsy, where you're kind of in a machine where you're lying down and your breast fits through the slot, and the radiologist numb you up and biopsy it that way. Now, some women do come in with something palpable, something that they feel, and if they feel that, and I'm seeing them, then I can biopsy them in the office, just numb the area up to get a sample, and then we can determine what it is. If someone has a biopsy for mammographic finding, really the majority of times it is benign, but there's at least about a 25% chance that it could be something. So that's why we want a suspicious area to be biopsied, to make sure it's not a cancer. The best preventative way to help prevent breast cancer is to get a mammogram to make sure that your breasts are fine, and then otherwise that it's just the normal things. Doctors always tell you to try to eat healthy, maintain a normal, a good weight for you, and those are the basic things. Otherwise than that, there's nothing specific to do unless you're really high risk. And then if you're really high risk, then you should see a doctor, and then we can go over things to help prevent developing breast cancer for you. So if somebody is diagnosed with breast cancer, then we offer treatment. So typically the first treatment with anyone with breast cancer is surgery. So for surgery, there's two choices. One is a lumpectomy and the other is a mastectomy. And there was a national study that started in the late 70s, early 80s that compared two groups of women. One group had a lumpectomy and one group had a mastectomy. There was a third group, but for our purposes, we'll put it to these two groups. And in this study, it showed that women who had a lumpectomy and women who had a mastectomy, their outcomes as far as survival, and that's what the study looked at, were the same. So this tells us that no one surgery is better than the other. They're both pretty equivalent. They are slightly different, though, in about what you need to do after the surgery. So if a woman has a lumpectomy, that means it's taking the area out, and typically the cancer is small, and it would require me just to make an incision to remove the tumor. If they have a lumpectomy, then afterwards they do have to have radiation therapy treatments. Those two go hand in hand. We really don't separate those for majority of women. And radiation is typically for 6 weeks, Monday through Friday. So every day you come to a radiation center and receive radiation. The treatments are very quick, about 15 minutes, but you have to do the radiation if you have a lumpectomy. Radiation is when rays, and you don't see anything, comes down and sort of sterilizes the rest of the breast. You don't lose your hair like chemo, but you would notice almost like a bad sunburn as the weeks go on, and your skin may peel, but the radiation oncologist will give you special creams to put on your breast. Then afterwards, the breast should come back to the normal complexion. If people have then we stop for a second and we'll go back to mastectomy. We do have a question, and the question is, what is a nodule in the breast? So a nodule is just a term that physicians can use just to describe a mass in the breast. So a mass is anything that you feel, the patient, or we feel. It doesn't mean necessarily that it is a cancer. So if you feel something in your breast that feels firm or round, and that's usually what a nodule can feel like, it can be several things. It could be a cyst, which is just a fluid-filled little cavity, and that's totally benign. I mean, it's a lot of instances you don't have to really do anything about it. Or it can be something solid, like a fibroadenoma, and that's a benign finding that can happen a lot to women in their teens, 20s, and 30s, and 40s. But it's very common in people in their teens and 20s. And in fibroadenomas, again, you don't necessarily have to do anything about it unless it starts growing. or it could be a breast cancer. So that's the job of myself and the mammographers, the radiologists, is to help figure out what that nodule or palpable little mass is, and we kind of work it up to try to figure that out. So that's a good question. It's a little layman's term and what someone might call a mass, and that's what a nodule is. So if we go back to the treatment of breast cancer, the other option is to have a mastectomy. And mastectomy, as you know, is just removing the entire breast. So if a person has a mastectomy, most likely, and there are some instances where this does not hold true, but most likely you don't need radiation. With mastectomy, we do remove the entire breast, but here at Wake Forest, we can offer some sort of immediate breast reconstruction by our plastic surgeons. And the reconstructive options are implant-based, using an implant, or it can be using your own tissue. And what's been popular recently is using what's called a DIEP flap. That's a deep inferior epigastric perforator flap, the long name of it. But basically it is taking the tummy fat and removing that and placing it up here the breast and preserving the muscle, the rectus muscle, so your muscle is tight, and then that fat in your abdomen can be used to create a breast. A lot of women like this because essentially you get a tummy tuck, even though the plastic surgeons don't say that, but that's really what you're getting. So you get that and then a kind of new breast. But it is a longer surgery. It's a very, very long and kind of a difficult surgery, and not everybody qualifies for it. So it's up to the plastic surgeon to determine which is best for you and what you want, the patient wants. Maybe they don't want to go through a long surgery, and then a lot of women just choose to have an implant placed. Well, another question we have is, who needs an MRI and thermography versus mammogram? So mammogram is still the standard of care, the best tool we have for screening people and for diagnosing breast cancer. So it's still the number one thing in the United States and Europe. As far as MRI, MRI is a very good tool. MRIs are more expensive than mammography, and they require you to have an IV to get this dye. So because it's more expensive, because you need this IV, not everybody gets that. So it can't, right now it's not used as a screening tool for the general population. But some women, we do recommend they get an MRI. So the women we definitely recommend get an MRI are people who are known carriers of the breast cancer gene, so who are known BRCA1 or 2 carriers. So these are women who've had genetic testing, and their testing has come back positive for having the breast cancer gene. So those women we do screen with MRIs once a year. Other people we screen are people who are high risk. So people maybe who have the genetic test but were negative, but they have their mom and their sister and their aunt and some other people in their family had breast cancer. So there are really a lot of people in their family that have cancer, and there's probably something genetic going on, but we might just not know about it yet, because we recently discovered these genes and have learned about them in the past 15 years. So those people can be screened. The other reason you would get an MRI is if we see something on mammogram, but again the person has a really dense breast, and maybe even the 3D doesn't quite see it as well, then we may recommend a person get an MRI. Or someone has a known breast cancer, sometimes we do recommend that they receive an MRI of their breast. So it's only for very specific cases, and if we're looking for a certain population, or if we're trying to see something specifically on maybe the mammogram can't see. Now thermograms are really controversial because they're not really what's really recommended as a standard of care. Because they're very non-specific. I mean, they're just measuring heat essentially, and what they say is if the area in your breast is hot, but maybe there's a tumor there because of the blood flow. But it doesn't necessarily mean because something looks hot. I mean, the rest of the body could be hot. Maybe you're hot. I mean, it's very not specific. So we really don't recommend thermograms as a choice for screening people. Another thing that people sometimes ask about is ultrasound, and they do have a screening ultrasound, but not every facility has it. Ultrasound definitely has to be used in conjunction with mammography, because ultrasound really is trying to determine if something is solid or if it's fluid filled. It has a certain role, and especially really good if someone feels something. If you feel something, you should get a mammogram, but if you definitely feel something, then you need an ultrasound to see if it's just a cyst, a fluid filled little ball, or if it's a solid area. So ultrasound is a different tool we also use. Those are the major imaging modalities we use to help look at women with breast problems. So getting back to the treatment of breast cancer, after surgery, then a person may go on to either chemotherapy or radiation. So a person who has a lumpectomy, like we said, definitely will receive radiation, and that's for 6 weeks, Monday through Friday. So it is a time commitment. It's really quick, and the radiation oncologists work with your schedule, but you do have to come for that. And chemotherapy, that's a different, whole different kind of set of rules why you would need chemotherapy. So a lot of women don't need chemotherapy. It depends on their type of cancer. So if their cancer is sensitive to estrogen, then they may not need chemotherapy. Maybe they can just take tamoxifen or another set of pills called aromatase inhibitors. That's where you take those medicines for 5 years. If a person's cancer is estrogen receptor negative, because there's 3 receptors and markers we look at for breast cancer: estrogen, progesterone, and this other one called HER2/neu. If they're estrogen negative, then they're definitely probably going to get chemotherapy, because we don't have a target to attack that estrogen receptor, because it doesn't exist on that tumor, or that tumor is not sensitive to estrogen. So those people will get some sort of chemotherapy. The other reason a person may receive chemotherapy is if there's cancer in the lymph nodes. So at the time of the surgery, we'll do what's called a sentinel lymph node biopsy. That's removing 1, 2, or 3 lymph nodes to make sure the cancer isn't spread there. And if there's cancer in the lymph nodes, then they'll usually get chemotherapy. A third reason is if their tumor is sensitive to this thing called HER2, they will receive Herceptin, which is a targeted therapy, but that targeted therapy, Herceptin, only works if you receive chemotherapy also. So it's a little complicated. It doesn't mean if you have breast cancer you're going to get chemotherapy. Not everybody receives chemotherapy. We do, however, tailor it to the person and their cancer. So when someone has breast cancer, it's very tailored treatment to you. So what your friend or your cousin got, or someone you might know, it may not be exactly what you receive. So we really do target it to the person, and that person also might be eligible for clinical trials that we have at Wake to help that particular type of cancer. And by enrolling in a clinical trial, you're helping women throughout the whole country. So it's really great if there's a trial available and people enroll in that. You're not helping only yourself, but you're really helping people throughout the whole nation and the world, because the trials in America are known throughout the world. So that's really good. So what makes our cancer services special? We have just a great team of doctors. We have really a largely female team of physicians. Myself, there's another female breast surgeon, Dr. Kiko Chiba, who just joined us. We're excited to have her here with us. And there's a radiation oncologist who specializes in breast, Dr. Doris Brown, so another female, and all she does is radiation oncology for the breast. And then as far as our medical oncologist, we have Dr. Alexandra Thomas, who's a head of breast medical oncology, and Dr. Susan Moline. We have Dr. Tiffany Avery and Dr. Steve Swarcher and Dr. Kleppen, who specializes in geriatric or patients. They all have to be over 75, so she has a special population of patients. So we participate in a multidisciplinary clinic. We all meet together and we discuss our new breast cancer patients together, and then as a team we tell the patient what our plan is, what we recommend for them. So that's unique for this part of North Carolina. It's the only place you really truly get that is in the eastern part of the state, but that's where you will see that here in our part of the state. And we have, again, our team is largely female, and that's very unique for North Carolina and even the country. So we also have great plastic surgeons we work with. They're wonderful. We have at least 4 or 5 plastic surgeons who just help us do breast, and we can offer newer techniques like the DIEP flap and other flaps that are available that you can only find here and at maybe 1 or 2 other institutions in the state, and otherwise you really have to go out of the state to find that. So we have people are very lucky to have that offering in our state. And we definitely have clinical trials that are available to help patients. So maybe the clinical trial could, if you participated in one, you may receive a medicine that you would not receive otherwise, and that could potentially be life-saving. So that is very helpful. Furthermore, we're an NCI designated cancer center. So we've gone through, that means we've gone through a lot of rigorous look from the National Cancer Institute in Washington, D.C., and has designated us as a center of excellence for cancer research and cancer treatment. And not every cancer center in the United States is NCI designated cancer center. It's very hard to be NCI designated, and we're proud that we've been that way for a while here at Wake Forest. Other things that people should look for are, again, family history. So one thing is just to know your family history. And a lot of times people can be confused about that, especially in the past. It might be hard to know what someone's grandparent died of or aunts, because maybe they didn't say what happened to them. But it's important to see if you can try to figure out if they had a cancer, what type it was, because we know certain cancers are linked, like breast and ovarian, or even breast and pancreatic cancer are linked. So it's important to know what your other relatives had. When should people start getting a mammogram? And this can be a little controversial due to, especially the United States Preventive Task Force came out with different recommendations from what the American the American College of Radiology and the American College of Surgeons recommend. So American College of Surgeons and American College of Radiologists at this point still recommend to get a mammogram at the age of 40, start at the age of 40 and do it annually. A U.S. Preventive Task Force says start at 50 and do it every 2 years. Right now, the only problem with doing this every 2 years is sometimes people can forget. They might have done one and then their doctor writes it down too, but then maybe 2 or 3 years later they're like, is this 2 or 3 years? Or people kind of get lost in what it is. Even the doctor gets lost. So right now, that's why we still encourage people to do it annually. And especially we encourage African American women to get their mammograms starting at age 40, because African American women tend to get breast cancer at a younger age than Caucasian women. So myself as an African American woman, we tend to get breast cancer in our late 30s or early 40s, whereas the average age for most women is in their mid-50s. So African American women have to be especially attuned to that and try to get their mammograms early. And if anybody feels a lump in their breast or anything, they really need to go to a physician to get it worked up. They at least need a mammogram or ultrasound. So anyone over the age of 30 who feels something in their breast, they'll come and get an ultrasound, but they'll also get a mammogram. If you're less than 30, people will get just an ultrasound only, because we'll start with that for people less than 30, but everybody else, they'll probably get a mammogram and ultrasound because they're feeling something. So that's what we have to, our tools we use to work those up. and breast self-exams are important. Actually, studies have shown they're not as sensitive as you think they would be. But, I mean, it's your own body, so you should examine your breast. And if you examine your breast and you feel something, then you should bring it to the attention of your doctor, because sometimes, some people's primary care may not do a breast exam, and they're waiting for you to tell them that you feel something, and then they can palpate the area too, make sure they're feeling it too. If they do, then they need to send you on to get some imaging of that area, because that can help us determine what it is. And if it is something that's solid, not a cyst, then that's the one that will require a biopsy. So all solid masses will need some sort of biopsy, either ultrasound guided or just like me. If you saw me, I would just fill the area and biopsy in clinic, or through the mammographers with stereotactic biopsy. So we really need to determine pathologically, or take tissue out to really look at it on the microscope to really determine what it is, because maybe it's benign, which would be good, and then you don't have to really worry about it. So breast health can be it can be rather complicated, but the best thing to do is to get your mammogram annually, and see your doctor if you're feeling something abnormal, and really know your family history. And that's important for any kind of cancer. You really have to know genetically what's going on with your family in the past. Additional, Wake Forest again has many different clinical trials. We have different locations. We see patients at our main cancer center, but we also see patients in Clemens. Also, in the near future, we'll probably be seeing patients in Greensboro also. So, it's easy to get in to see us. We do have a fast way to get in, and basically you can call just 336-716-WAKE, and they'll help get an appointment to see one of us and help work up any breast problems you might have.